Okay, so in this video we are going to talk about the range of motion examination for the cervical spine. Now if you see the range of motion examination, there are three stages: active movements, passive movements, and resisted isometric movements. Active movements are the first to carried out or check when you check the cervical spine examination. When you check the cervical spine, try to examine neck and both upper limbs, because most of the symptoms in the upper limb are coming from the neck, or unless and until if you find a definitive trauma to any of the peripheral joints like shoulder, elbow and wrist. Now, when you see the active movements, there are active movements: flexion, extension, side flexion left and right, rotation left and right, combined movements, repetitive movements and sustained movements. As I said earlier, active movements are first to carried out, and most painful active movements should be or must be checked last. If the patient says I have pain in extension of the cervical spine, check that last. Okay, now active movement examination and sitting position. Before I start with the active movements, let me talk a little bit about a protraction and retraction of a cervical spine. Very important. During the protraction of the cervical spine, the upper cervical spine extends and lower to mid cervical spine flexes. And exactly opposite occurs during retraction. So retraction, the upper cervical spine flexes and lower to mid cervical spine extends. Now, females tend to have a greater mobility in cervical spine compared to males, just except in cervical flexion. But the change in range of motion is not considered huge between male and female. Second, ranges available in a cervical spine decreases when the age advances, just except the rotation at the C1 and C2 cervical spine, that even may increase. Now we'll start with the flexion first. So when you check active range of motion, you do overpressure. So overpressure helps the examiner to check the end feel of the cervical spine. Now there are two end feels. If there is a physiological end feel, that is active, and anatomical end feel, that is passive. When any examiner check three combined movements, rotation, side flexion and extension, extreme caution must be practiced because it compresses the vertebral artery. Now, when you check the active movements, C0 to C2 or upper cervical spine, when it moves, the movement can be isolated. It don't bother the rest of the cervical spine. So testing can be done in two parts: testing the upper cervical spine from C0 to C2 and testing the lower cervical spine from C2 to C7. We'll start with the flexion first. So as I said earlier, flexion, when you check the upper cervical spine, very easy. Ask the patient to nod or ask the patient to touch the chin to the Adam's apple. Check for the other symptoms of cervical myelopathy, where the radiating pain or shock-like sensation moves to the extremities. But if you check the orthopedic standpoint of view, check the distance increase between the mastoid process and a transverse process of C1 cervical vertebra. Check for any hypomobility or hypermobility. Flexion maximum range of motion possible is between 80 to 90 degrees, where a patient can able to touch the chin to the chest when the mouth is closed, but a width of even 2 fingers between the chin and the chest should be considered normal. Now, I want to talk a little bit about a group of muscles. So flexion, there are two groups of muscles: deep neck flexors and sternocleidomastoids. Now, when the deep neck flexors will initiate the movement, the nose will lead the movement. But when there is a weakness in deep neck flexors, both sternocleidomastoid muscle will initiate the movement. So the jaw is elevated and the chin is elevated and the jaw will initiate the movement. During flexion, intervertebral disc enlarges posteriorly, facet size increases up to 20 to 30%, and a vertebra shifts forward. We'll talk some about extension. So extension normally limited up to 70-degree range of motion, but there is no anatomical stop to limit the extension. In extreme ranges of extension, patient can reproduce the same pain and symptoms of from whiplash injury or even the cervical strain. And in extension, the atlas tilts upward and it compresses the posterior part between the occiput and the atlas. Move towards the side flexion. Now side flexion is little interesting. Side flexion towards left and right. When you check the active range of motion for side flexion, it is possible up to 20 to 45 degrees but in sitting position. But when you check the side flexion passively, when the patient is in supine lying position, it may go up to 75 to 80 degrees. Now what to check? When you check the side flexion in patient active range of motion, you check the transverse process palpation on the convex side. Next, moving towards the rotation. The rotation available range of motion is between 70 to 90 degrees. Now, as I said earlier, the coupled movement. So rotation and side flexion always occurs together. So you cannot isolate. Most rotation occurs between C1 and C2. So if the patient is able to rotate the spine up to 40 to 50 degrees, there is more than unlikely that patient has any problem in C1, C2 articulations. Repetitive movements and combined movements are checked as the patient says, like combination of side flexion and rotation reproduce the pain, so check that movement as it is. But as I said earlier, check it last. I want to end this video by one special test, cervical flexion-rotation test. So in cervical flexion-rotation test, the pathology between C1, C2 articulation can be checked. Ask the patient to actively flexes the cervical spine at the maximum ranges possible. In the second step, holding that position, ask the patient to rotate a cervical spine. So any pathology between C1, C2, pain and headache can be reproduced. So that means that the cervical flexion rotation test is positive. In my next video, I'll try to cover passive movements and resisted isometric movements of the cervical spine. Thank you.